Usually when we think about a drought, we picture it on this like macro level.
Right, like a dried up riverbed or something.
Exactly. Cracked earth, a reservoir that's slowly receding. It's a very visible, obvious lack of water.
You can physically see the shoreline dropping. It's totally undeniable.
But what if that drought was happening inside your own body? And what if it was happening in a place that no one ever really talks about?
Where the cracked earth isn't visible at all.
Right, but the impact on your life is monumental. So, welcome to this deep dive. Today, our mission is to unpack one of the most common, yet honestly least discussed, symptoms of Sjogren's disease.
Yeah, we're taking a really hard look at how Sjogren's affects the body's mucous membranes, specifically causing severe vaginal dryness.
It is a topic shrouded in so much silence.
It really is. And that's a huge disservice to the patients actually navigating it.
Yeah.
I mean, the general public and even a lot of GPs, they know Sjogren's for causing dry eyes and a dry mouth.
The classic symptoms, yeah.
Right. But its effect on the mucous membranes goes so much deeper. It severely impacts sexual health, relationships, and just, daily physical comfort.
So we have gathered a seriously fascinating stack of sources for you today to kind of break this wide open. We're looking at clinical guidelines from the Menopause Society and Johns Hopkins.
Excellent resources.
Yeah, and some incredibly practical patient resources from Insightful Med and FemaPharma. Plus, this truly groundbreaking PhD thesis out of the University of Groningen that is, well, it's completely shifting the medical understanding of this symptom.
Oh, that Groningen thesis is absolutely pivotal because for decades, the medical community just wrote off vaginal dryness in Sjogren's patients as a side effect of early menopause.
Like it was just standard aging.
Exactly. They assumed it was just a localized hormone issue.
Which totally ignores the underlying mechanics of the actual disease, because the newest research proves it is actually a totally different, really fascinating vascular issue.
So it's all about the blood vessels.
All right. So today we are going to break down the actual science of what's happening at a microscopic level. And, dismantle the stigmas around talking about it and look at the highly effective treatments that are out there.
So to understand why this is happening in the vaginal tissue, we first really need to reframe how we look at Sjogren's as a whole.
Okay, let's start there.
If you are living with this condition, you probably already know it's a chronic systemic autoimmune disease. Your immune system basically gets confused and targets your exocrine glands.
And those are the ones responsible for producing fluids, right?
Yeah.
Like saliva and tears.
Exactly. And just to give a picture of who this affects, it predominantly impacts women. There's actually a 9-to-1 female-to-male ratio.
Wow, 9-to-1. That's a massive skew.
It is, and it usually shows up between the ages of 40 and 60. Diagnosis often involves checking for very specific antibodies like anti-Ro and anti-La and measuring actual moisture loss.
Right, like they do that Schirmer test for the eyes or a spit test for the mouth.
Yeah, exactly. But while the dry eyes and mouth are the hallmark sicca symptoms, the disease is systemic. It can cause brain fog, joint pain that mimics rheumatoid arthritis, and crucially for our discussion today, severe dryness of other mucous membranes, particularly the vagina.
Which makes sense if you think about it.
Right. Women with Sjogren's report vaginal dryness 2 to 3 times more often than women of the exact same age without the disease.
I mean, if we think of the body's moisture network like a city's plumbing system, Sjogren's is like this rogue element breaking into the main pumping stations, the tear ducts and salivary glands.
That's a great way to visualize it.
Yeah, and shutting off the water supply. But it doesn't just stop there. It travels down the network and starts tampering with the local infrastructure in the reproductive system, too.
And that systemic tampering is exactly where the medical community got it wrong for so long.
How so?
Well, medical researchers saw the local infrastructure failing. They saw these women in their 40s and 50s presenting with severe vaginal dryness, and they made a massive assumption.
That it was just menopause.
Right. They figured the local valve shutting off must just be standard estrogen loss.
Because that's the textbook cause for that exact demographic.
Exactly.
But reading through that Groningen thesis, this assumption was entirely turned on its head. I mean, the researchers systematically proved that the whole early menopause theory was just a myth.
Yeah, it completely blew that theory out of the water. Let's look at the biology of what actually happens in healthy women during normal menopause.
Okay.
As the ovaries stop producing as much estrogen, a very specific cascade occurs. The drop in estrogen causes the vaginal tissues to become thin and lose elasticity.
That's vaginal atrophy, right?
Yes, vaginal atrophy. And that estrogen drop doesn't just change the tissue structure, it changes the entire local ecosystem. The actual microbiome of the vagina shifts.
Because the environment is changing.
Right. A healthy premenopausal vagina actually relies on estrogen to fuel the production of glycogen in the tissue.
Okay, glycogen, like a sugar.
Exactly. And that glycogen feeds lactobacilli, which are the good bacteria. Those bacteria then produce lactic acid to maintain a slightly acidic protective pH level, usually around 3.8 to 4.5.
So it's this perfectly balanced little ecosystem.
It really is. But when estrogen drops in menopause, the glycogen drops, the good bacteria basically starve, the pH rises, and the whole microbiome changes. It becomes much more susceptible to irritation and infection.
Gotcha. So historically, doctors looked at Sjogren's patients, saw the vaginal dryness, and just assumed this exact estrogen loss cascade was happening to them early.
Exactly. But the Groningen thesis proved that completely wrong for premenopausal women with Sjogren's.
Because these women were experiencing debilitating dryness well before they hit menopause.
Right. And the researchers actually looked at the tissue biopsies to see why. They took biopsies from premenopausal women with Sjogren's who were suffering from severe dryness and compared them to completely healthy controls.
And what did they find?
The findings were astonishing. There were 0 signs of estrogen deficiency. None.
Wait, really? None at all?
None. The epithelial thickness, like the actual physical thickness of the vaginal wall, was totally normal. It wasn't thinned out or atrophied even a little bit.
Oh, wow. So the tissue itself was structurally sound.
Yes. And the pH was also completely normal, remaining right in that healthy 3.8 to 4.5 range.
That's wild.
And to top it all off, when they sequenced the vaginal microbiome of these Sjogren's patients, it was a perfect match to the healthy controls.
So the good bacteria were fine.
Thriving, actually.
Yeah.
There was no dysbiosis, no abnormal bacterial shifts at all. It was a perfectly healthy, robust microbial ecosystem.
Just existing inside an incredibly dry environment.
Exactly.
But wait, if their hormones are fine, their tissue thickness is fine, their pH is perfect, and their microbiome is totally normal, then where on earth is the dryness coming from? Like, what is actually broken in the plumbing?
Right. It's a massive biological paradox, and that paradox is what led the researchers to the real culprit. If it's not a hormone problem and it's not a classic gland problem, it has to be a delivery problem.
A delivery problem.
Yeah, it's a vascular mystery. It's a blood vessel issue.
Okay, so not the glands, the blood vessels.
Yes. And to understand this, we really have to correct a major misconception about how vaginal lubrication actually works.
Okay, lay it on us.
Well, unlike the mouth or the eyes, where you have these large, dedicated glands visibly pumping out saliva and tears, the vagina doesn't primarily rely on glands for its moisture.
I feel like that is a huge surprise to a lot of people.
It usually is.
If there are no big glands churning out fluid, where does the moisture actually come from, especially during sexual arousal?
The vast majority of vaginal fluid is actually a transudate.
Transudate, okay.
Yeah, so the vaginal wall is packed with this very rich, dense network of blood vessels. When a woman becomes sexually aroused, blood flow to the pelvic area increases massively.
Right.
The blood vessels dilate, they widen, and as they engorge with blood, hydrostatic pressure builds up inside them.
Like turning on a hose with a kink in it?
Kind of. That pressure physically forces blood plasma to filter out of the vessels, pass through the vaginal tissue, and bead up on the surface of the vagina as a highly lubricating fluid.
So the lubrication is essentially filtered blood plasma just being pushed through the tissue by blood pressure.
Exactly.
That is an incredible system.
It's an elegant hydrostatic pressure system. But when the Groningen researchers looked at those Sjogren's biopsies under the microscope, they found a critical failure in this exact vascular delivery mechanism.
Okay, what was failing?
The cellular makeup of the blood vessels in the vaginal wall was fundamentally altered. They specifically looked at the vascular smooth muscle cells.
And what do those cells do?
Those smooth muscle cells are the ones that wrap around the blood vessels. They are the mechanical engines that allow the vessels to actively dilate and constrict.
Oh, I see.
In the women with Sjogren's, there was a significantly decreased number of these vascular smooth muscle cells.
Which means the blood vessels are physically damaged.
Right.
They're losing their mechanical ability to widen, engorge, and actually allow that blood plasma to filter through.
Exactly. It is a clear indication of endothelial damage or vascular dysfunction. And the biopsies didn't just show missing smooth muscle cells, they showed us the weapon that destroyed them in the first place.
The immune system saboteur doing what it does best.
Yep. The tissue samples showed dense, abnormal concentrations of immune cells, specifically CD3 T lymphocytes and CD20 B lymphocytes.
Just swarming the air.
Swarming it. They were clustering right around the epithelial layer and the blood vessels. And furthermore, they found very high levels of a specific chemokine called CXCL10.
Okay, chemokines act like chemical distress beacons,
Yeah.
right? Drawing the immune system to a specific site.
You nailed it. And CXCL10 is specifically induced by interferon, which is a major driver of inflammation in autoimmune diseases.
So connecting this back to the bigger picture, the systemic immune system is in this state of chronic hyperactivation.
Right.
It's using that CXCL10 as a homing beacon, sending these T cells and B cells directly into the vaginal tissue.
And that creates chronic, localized inflammation that physically damages the local blood vessels and destroys those smooth muscle cells.
Wow. So to go back to our city plumbing analogy, it's not that your body forgot how to make the transudate fluid. It's that your own immune system has essentially set up a militarized roadblock on the local highways, your blood vessels.
That's exactly it.
Because those vessels can't dilate, the delivery trucks carrying the fluid physically cannot get through to the surface when they are needed most.
The fluid is trapped because the vascular delivery system is under active immune attack.
That is just mind-blowing. But now that we know the microscopic mechanics of why this happens, we really have to talk about the human toll.
Yes, absolutely.
Because a failing vascular delivery system in this highly sensitive area causes immense physical pain.
It does. We are looking at a silent epidemic of dyspareunia, which is the medical term for painful sex.
And the statistics from the clinical resources are really sobering.
They are. 62% of Sjogren's patients rate sexual activity as an important part of their lives, yet 68% report that their sexual function is negatively affected by their disease.
Over 2/3 of patients are suffering from this.
Yes.
And reading through the patient resources, this isn't just like mild discomfort. The friction caused by a lack of transudate leads to micro-tearing, intense burning, and severe chronic pain.
It's debilitating, and in some cases, chronic dyspareunia is actually the very first presenting symptom of Sjogren's, long before the dry eyes or dry mouth become unbearable enough to seek a diagnosis.
Which is so tough, because if that's your first symptom, your mind doesn't immediately jump to, oh, I have a systemic autoimmune disease.
Right, not at all. And the psychological impact is profound. The data explicitly links the specific symptom to high rates of anxiety, depression, relationship dissatisfaction, and obviously a significantly reduced overall quality of life.
But, the most staggering statistic from our stack of research is that despite this massive impact on quality of life, only 25% of women actually seek treatment for it.
Only 1 in 4.
The suffering in silence is just pervasive. And our sources point to fragmented care as a major culprit here.
Yeah, the modern medical system is highly specialized, which is great for acute, isolated problems, but it is terrible for systemic diseases like Sjogren's that affect the entire mucosal infrastructure.
Because if you're managing Sjogren's, you might be bouncing between a rheumatologist for your joint pain, an ophthalmologist for your eyes, and a dentist for your lack of saliva.
Exactly. And the mucosal environment of the vagina just falls into this specialist no man's land. Who is actually connecting the dots?
So if a listener is in that exact situation, bouncing between all these doctors, who are they actually supposed to talk to about this?
This is where patient advocacy becomes so critical. Often none of those specialists will think to ask about your sexual health because it falls outside their narrow diagnostic window. The best specialist to manage this specific symptom is a gynecologist. Ideally one who focuses on menopausal symptoms or sexual medicine, even if you are entirely premenopausal.
Because a gynecologist understands the nuances of that local tissue environment better than anyone else in your care team.
Gynecologists treat vaginal dryness and dyspareunia every single day. There's absolutely zero reason to feel embarrassed bringing this up to them.
But the reality of fragmented care means you have to proactively make that appointment yourself.
Yes, you have to explicitly state the connection. You go in and say, I have Sjogren's, it is a systemic mucosal disease, and it is causing severe vaginal dryness that I need help managing.
Which leads us directly into the solutions. Since you have to advocate for yourself, We want to equip you with the exact tools and treatments available in the clinical guidelines.
Yes, let's talk treatments.
Let's start with the over-the-counter options, because the resources from FemaPharma and Insightful Med draw a very hard line between the two main types of non-hormonal management.
They do. The foundation of non-hormonal management is understanding the distinct difference between moisturizers and lubricants.
Right.
Patients, and honestly even some doctors, frequently conflate the two, but they serve entirely different physiological functions.
Let's break down the moisturizer first. Looking at the guidelines, a moisturizer with hyaluronic acid is basically a long-term tissue rehabilitation plan, isn't it?
Exactly. A vaginal moisturizer is designed for daily tissue health and comfort. You use it regularly, typically 2 to 3 times a week, entirely independent of sexual activity.
So it's not an on-demand thing.
No, it gets absorbed deep into the tissue to relieve chronic dryness, itching, and irritation. Hyaluronic acid is the gold standard ingredient because it's a molecule naturally found in your body that binds to water up to 1,000 times its weight in water.
Wow.
Yeah, so it helps keep the mucosal tissues plump, elastic, and continuously hydrated on a cellular level.
So that is the baseline maintenance for the tissue itself. Lubricants, on the other hand, are strictly for on-demand use.
Yes. Lubricants are used immediately before and during sexual activity to reduce friction. They do not absorb deeply. They're designed to sit on the surface of the tissue to artificially replace the missing transudate fluid we talked about earlier.
Think of it this way. Using a lubricant to try and cure your daily vaginal dryness is like putting on a raincoat to cure dehydration.
That is a perfect analogy.
Right. You need the daily moisturizer to actually hydrate the tissue itself from the inside, and you use the raincoat, the lubricant, just to protect the surface during the friction event.
You absolutely need both, but you use them for entirely different reasons. For lubricants, water-based or silicone-based products are standard.
And the Johns Hopkins guidelines even suggest pure olive oil or vitamin E oil, right?
Yes, as simple, effective alternatives, provided you aren't using latex condoms, of course, because oil degrades latex.
Good caveat. But people with Sjogrens have to be incredibly careful about the ingredient lists on these over-the-counter products, don't they?
Oh, absolutely. Their mucosal tissue is already compromised, inflamed, and lacking its natural protective barriers. Reading the labels is non-negotiable.
What should they be looking out for?
You want to strictly avoid products that contain glycerin. Glycerin is hyperosmolar, meaning it actually pulls water out of the surrounding cells.
Yikes. So it makes it worse.
Much worse. It can severely increase dryness and irritation in already compromised tissue. You also need to avoid parabens, artificial flavors or fragrances, and anything marketed with warming or cooling chemicals.
Because those just trigger more irritation.
Exactly. You want sensitive skin formulas only, ideally with a pH that matches the vagina's natural 3.8 to 4.5 acidic environment to keep that healthy microbiome intact.
Okay, but what happens if you do all of this? You use the hyaluronic acid moisturizer diligently, you have a high-quality silicone lube, you try it for 4 weeks, and the friction and pain are still there.
If the non-hormonal over-the-counter options fail to provide adequate relief, the clinical guidelines recommend stepping up to prescription therapies. And the absolute gold standard here is localized vaginal estrogen.
Wait, hold on. If the Groningen thesis proved that estrogen deficiency wasn't the root cause for these premenopausal patients,
Yeah.
why is estrogen the gold standard treatment?
It definitely seems counterintuitive at first glance. The root cause is vascular damage from immune infiltration, right?
Right.
However, applying localized estrogen directly to the vaginal tissue acts as a powerful restorative and angiogenic agent.
Angiogenic meaning it promotes the growth of new blood vessels.
Exactly that. Even if your systemic estrogen levels are totally normal, adding topical estrogen to that specific area thickens the vaginal epithelium, increases the production of endothelial nitric oxide, which helps blood vessels dilate, and literally forces the growth of new, healthy blood vessels.
Oh, wow. So it essentially overrides the immune roadblock by building new infrastructure and forcing the vessels to open up.
Yes, it promotes natural transudate moisture production by fixing the local blood supply.
It's like applying a highly targeted super fertilizer directly to struggling soil to force a new root system to grow.
Great way to put it. And it comes in several low-maintenance forms. It's available by prescription as low-dose creams you insert with an applicator, small tablets, or soft gel inserts like Imvexy, or even a flexible ring like Estrin.
And the ring just stays in there.
Yeah, you place it in the vagina and leave it for 90 days for a slow, continuous release.
We do need to address a major hurdle with this treatment, though, which is the FDA black box warning. Because a patient might get this targeted cream open the box, and just be confronted with a terrifying pamphlet warning about blood clots, stroke, and breast cancer.
Oh, that warning is a massive source of anxiety, and it tragically prevents so many women from using a highly effective treatment.
Why is it on there if it's localized?
Well, the FDA currently mandates that broad black box warning for all estrogen products, regardless of how they are administered. But that specific warning is based on historical data from high-dose systemic oral estrogen pills.
Pills that circulate through your entire bloodstream and affect every major organ system.
Exactly, which is fundamentally different from how localized vaginal estrogen operates in the body. The clinical pharmacokinetic data is incredibly clear here. The amount of estrogen absorbed into your general bloodstream from localized vaginal treatments is biologically insignificant.
So it just stays locally where you apply it.
Yes. It is considered highly safe for the vast majority of women. Of course, anyone with a history of estrogen receptor-positive cancers should always have a shared decision-making conversation with their oncologist, but for most, the systemic risk is virtually zero.
And if someone still cannot, or just prefers not to, use an estrogen product, the Menopause Society guidelines highlight some excellent scientifically backed alternatives.
Yes, there is an FDA-approved vaginal insert called Prastrone, which is a localized form of DHEA.
And DHEA is a precursor hormone, right?
Right. The local tissue can convert it into what it needs to restore cellular health without acting as direct estrogen. There is also an oral non-hormonal pill called ospemifene.
How does that work?
It is a selective estrogen receptor modulator. So it acts on the estrogen receptors specifically in the vagina to treat dryness and rebuild tissue without actually being systemic estrogen.
So the toolkit is incredibly robust, the treatments exist, the science is really clear, and the underlying mechanisms are finally being understood as a complex vascular issue rather than just a simplistic hormonal one.
Which means you do not have to accept this as an untreatable consequence of the disease. By understanding how the mucosal infrastructure works, the distinct roles of daily moisturizers and on-demand lubricants, and the restorative power of localized prescription therapies, patients can effectively bypass the immune system's roadblocks.
They can reclaim their physical comfort.
Absolutely.
Before we wrap up, I want to leave you with a forward-looking thought based on everything we've uncovered in these sources today. We've spent a lot of time discussing localized treatments, creams, inserts, rings.
Right.
But if we follow the logic of the Groningen thesis to its natural conclusion, what does the future of treating this actually look like?
The implications are fascinating, honestly, because if we now know that vaginal dryness in Sjogren's is fundamentally caused by vascular dysfunction and immune infiltration,
Driven by that interferon and the CXCL10 chemokine.
right, could the future of treating this symptom move away from localized vaginal creams entirely? Researchers are starting to ask if highly targeted immune-modulating biologics that stop the interferon pathway, or even systemic cardiovascular drugs that protect endothelial function, could they prevent the blood vessels from being damaged in the first place?
Wow. That suggests a profound paradigm shift. Instead of just treating the cracked earth at the surface, future therapies might actually fix the systemic plumbing at the source.
It's a very exciting area of ongoing research.
Well, thank you so much for joining us on this deep dive. Keep asking questions, keep connecting the dots in your own health research, and never hesitate to advocate for the comprehensive care your body truly needs.